You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology. And this is This Week in Cardiology for September 19th, 2024. This week, listener feedback, potassium levels after cardiac surgery, safety of cardiac devices, disparities in preventive care, and stopping trials early, as well as an update on the SHAM-PVI trial. First, let's do some listener feedback. I received a nice comment on my discussion of the MATTERHORN trial, which was transcatheter edge-to-edge repair of the mitral valve versus mitral valve surgery in patients with functional mitral regurg. The primary endpoint of a composite of death, heart failure, hospitalizations, mitral valve reintervention, assist device implant, or stroke was better at 1 year in the transcatheter edge-to-edge arm. It was 16.7 versus 22.5. The authors also reported safety events which were higher in the surgery arm due to post-op bleeding in AF, and I had said in the podcast such was a sort of ridiculous thing because bleeding in AF are expected after surgery. Dr. Stanton Rowe, who commented, did not agree. He wrote, "Are you suggesting that we should ignore AFib and bleeding complications from surgery because they are known and expected? These outcome complications," he wrote, "matters to patients. They belong in the study as important endpoints." Okay, this is a good set of questions and a good point. My take of MATTERHORN is that counting outcomes at only 1 year biases the results against surgery. We saw, for instance, that Kaplan-Meier curves were coming together over time. Dr. Rowe's question highlights the difficulty in comparing totally different procedures. In MATTERHORN, these were 70-year-old patients with pretty good ejection fractions. Their outlook is longer than 12 months. And inherent in cardiac surgery is post-op AFib and a higher rate of bleeding. Now, you could list these rates, but they come with the procedure. The question patients with this condition have is, how am I going to be at 2, 5, and 10 years? If the outcomes are the same at 5 years, then of course, you go with the transcatheter procedure. But if the transcatheter procedure is worse, and say it leaves more mitral regurgitation, then patients have a difficult decision to make. Now, I remind you that the original CABG versus medical trials were quite close. In the very famous USEF meta-analysis, the life expansion was about 6 months, and patients take about 3 months to recover from bypass surgery. And, as I've mentioned previously, in the STITCH trial, left ventricular dysfunction and coronary disease, surgery versus medicines, it took 10 years for surgery to beat medicines. In these cases, I'm not sure why a patient would choose the upfront complications from surgery. What we need to know in surgery versus device trials is what happens long after 1 year. All right, next topic, post-cardiac surgery AF. So speaking of AF after cardiac surgery, the ESC meeting featured yet another RCT testing a strategy to prevent AF after the heart is operated on. The TIGHT-K RCT tested 2 strategies of potassium replacement, a relaxed approach to potassium replacement versus tight control. Now, before I tell you the results, we should think back to the trials testing aggressive versus lenient control of anything in medicine. I can't think of many trials in which more is clearly better than less. Maybe the SPRINT trial of lower blood pressure targets, but that trial had nuances. In the Type K trial led by first author Benjamin O'Brien, whose author affiliations list Germany, London, and Cleveland, about 1,700 post-CABG patients, mean age 65 years, were randomized in 23 centers in the UK and Germany to a strategy of replacing potassium to keep levels above 4.5 milliequivalents per liter, or a relaxed strategy of 3.6 milliequivalents per liter. Now, since relaxed potassium replacement is easier, the authors test this as a non-inferiority trial, and that is totally reasonable because when using non-inferiority of a new therapy, the new therapy has to offer something less invasive, less costly, less burdensome. The primary endpoint of clinically detected new onset AFib in the first 5 days after CABG was 26.2% in the tight K group and 27.8% in the relaxed K group. This tiny difference easily reached non-inferiority for the relaxed arm. In fact, the 95% confidence intervals went from minus 2.6% better for the tight group to 5.9% worse, which was less than the 10% risk difference non-inferiority margin. The per-patient cost was also significantly lower in the relaxed arm, of course, given less potassium. And the authors concluded that, quote, for AFib prevention, supplementation only when serum potassium concentration fell below 3.6 was non-inferior to the current widespread practice of supplementing potassium to maintain a serum K greater than or equal to 4.5. The lower threshold of supplementation was not associated with any increase in dysrhythmias or adverse clinical outcomes. My comments. First, I did not know that, as the authors write in the introduction, that many clinicians believe that serum potassium concentrations influences the risk of atrial fibrillation in critical illness, and frequent potassium supplementation in an effort to maintain high normal levels is now a routine practice in many centers worldwide for the prevention of AFib after cardiac surgery. I did not know that people thought this. So, excellent. Good on the investigators for subjecting this plausible mechanistic dogma to empirical study with an RCT. Of course, this work is not going to win a Nobel Prize, but it is important to do these studies, to subject our ideas, our dogma, to proper trials. And I think this work is clinically actionable. They found no other disadvantages to the relaxed strategy, and it costs less and is surely less burdensome for the staff. And finally, I realize it's only one study, but this is yet another example wherein policies that make sense are implemented. Sure, it's reasonable to conclude that potassium, being an electrically active ion, one that is clearly important in the genesis of arrhythmia, might be an important thing to maximize. But, while low potassium and high potassium are clearly bad for the heart, the Type K trial shows that the difference between a low normal and high normal is not important, and that is really good to know. All right, next topic is the evidence base for new cardiac devices. New things in cardiology scare me, just a little. I lived through some terrible disasters with ICD leads. The worst was the Medtronic Sprint Fidelis lead. It was this bright blue and thinner lead. Everybody was excited about it. The problem was that these leads failed at a higher rate than the bulky tried and true leads. And I know that sounds like a benign sentence. Quote, they failed at a higher rate. Well, failure meant sensing noise and the device thinking it was ventricular fibrillation, and when that happens, patients got wide-awake shocks. Pacer-dependent patients didn't pace at all, and they had syncope. Back in my younger days, I was a rapid and early adopter, and we had tons of these bad leads. And I don't mean to pick only on Medtronic. All the device companies have had different recalls. But this Sprint Fidelis lead was really bad. Many patients had severe PTSD from it. Well, the Annals of Internal Medicine has published a survey observational study that set out to characterize Class 1 recalls of cardiovascular devices, as well as to describe the evidence supporting device approval. The first author is Claudia C. The senior author is Kushal Kadaki. Now, this paper was not good news for early adopters. A Class 1 recall, FDA, is the most serious recall. The authors write, the agency recalls according to their severity, with Class 1 designations reserved for situations where the FDA deems that use of a device would place a patient at increased risk for serious adverse health consequences or death. Although 1% of FDA-authorized devices are subject to Class 1 recalls, the recalls affect millions of patients and take years to resolve. Second background point, devices are approved via two pathways. A 510K pathway wherein the maker only needs to show that the device is similar to approved devices. This is a softer way to get approval. The other way to get a device approval is with what's called a pre-market approval pathway, wherein there is usually evidence of safety and efficacy. The FDA can require post-approval studies at the time of a pre-market approval. This is akin to ordering surveillance after approval. The authors of the Annals paper studied Class 1 recalls from 2013 to 2022. They noted 137 recalls involving 157 devices. Nearly 3/4 of these were moderate risk devices that were approved through the softer 510K pathway. About a third were high-risk pre-market approval devices. The most common reason for recall was a device design issue. About 1 in 4 devices had multiple Class 1 recalls. And here I think is the most important finding. Most studies use surrogate and composite measures as primary endpoints. The majority of studies, 2/3 of studies, were non-randomized and open label. 22, or nearly half, of the pre-market approval devices had required post-approval studies, with 14 reporting delays. Get this, no 510K devices were subject to post-market surveillance. Now, I just told you that the majority of Class 1 recalls were devices approved through the 510K pathway, and now there is this, no 510K devices were subject to post-market surveillance. A summary sentence that the authors wrote captures the essence of the paper. Quote, medical devices later recalled due to safety issues often had little clinical evidence supporting their original authorization. The authors offered numerous examples of this, of how pre-market evidence leads to trouble. One was Boston Scientific's VC venous stent system was approved in 2019 on the basis of a pivotal study using the surrogate measure of vessel patency at 12 months after implantation of an iliofemoral stent. In 2021, however, nearly 35,000 units were recalled after reports of stent migration, with clinicians requested to cease device implantation. So my comments, this paper has policy implications that are beyond the scope of clinical medicine. I don't know much about policy, but the fact that FDA did not use its authority to require post-market surveillance for many devices is worrisome as a clinician. In fact, the authors note that 80% of surveyed doctors report only a limited understanding of FDA's processes, and I guess I would be in that 80%. And I'm not sure it's feasible for us to become facile in how the FDA works, but this study and my experiences in the past with horrific ICD lead issues over the previous decade drives my medically conservative approach to new stuff. When new devices come to market, there is often great enthusiasm, there's lunches, there's key opinion leaders, there is excitement. It's like a tailwind on a bike ride. But we should have questions in our mind. What was the pre-market evidence, and what is the post-market surveillance like? This paper clearly shows that caution with new devices is wise. All right, next paper is about disparities in healthcare. JAMA Network Open has published a large observational study of 1.5 million patients seeking preventive care. The primary question and outcome was the frequency of insurer denials for preventive services. They did subgroup analyses were done, and they assessed outcomes across patient household income, education, and race and ethnicity. This was a Toronto-based team, first author Alex Hoagland, PhD. For each enrollee in the study, they identified the use of 7 preventive services recommended by the U.S. Preventive Services Task Force, and these would have been subject to the Affordable Care Act preventive care provision. These were contraceptive administration, breast cancer screening, cholesterol screening, colorectal cancer screening, depression screening, diabetes screening, and wellness visits. So basically, this group sought to examine the association with patients' social determinants of health and insurance claims denial for these preventive services. And there were a couple major findings. Patients with lower incomes experienced denials more frequently than patients with higher incomes, as did those with less education or those from minoritized racial and ethnic groups. The most common denials were for diabetes screening, depression screening, and cholesterol screening. Second major finding, differences across income and race and ethnicity remain significant even after adjusting for patient geography, service type, and insurer. Third major finding, services for at-risk populations, including contraceptive administration or mental health screenings, were associated with higher denial rates than other preventive services. So my comments. Obviously, we all know that there are disparities in health outcomes. Basically, rich people do better than poor people, and I don't know if that can ever be eliminated, but it seems right to try and reduce these gaps. I'm not an epidemiologist, and this paper had some serious statistical maneuvers. There were a lot of adjustments made. In other words, the research team had a lot of choices of covariates to adjust for, so I'm always thinking about what a multiverse analysis would have shown. But I have little doubt that there is unequal insurance denials based on income, race, and education level. But, the reason I highlight this study is less about the associations and more about the concepts of preventive care. The Affordable Care Act in the U.S. allows for free preventive care, but that assumes that preventive care improves health. My question is, does it? I know of no RCTs, for instance, of depression screening or diabetes screening. We already know that RCTs have shown really no benefit to wellness visits. Colorectal cancer screening is also, there is some improvement in overall mortality with flexible sigmoidoscopy, but the big colonoscopy trial in New England Journal of Medicine was negative for overall mortality. Mammography may reduce breast cancer deaths, probably does, but pooled data show no differences in overall mortality. So my point is that the way to fewer health disparities is unlikely to come through better access to preventive screening. In fact, I have long believed that healthcare has little role in improving disparate health outcomes. Rather, this seems more like a job for society and policy decisions. If we could somehow lessen the gaps between rich and poor, a certain side effect of that would be decreased health outcomes disparity. Of course, how best to reduce gaps between rich and poor is many levels higher than a cardiology podcast could ever sort out. Okay, next topic is stopping trials early. Jack has published a very nice piece from Dr. Sanjay Kaul and Javid Butler on stopping trials early, insights from the recent pivotal trials in chronic kidney disease. I learned a lot from reading this short piece. They focused on 3 trials looking at SGLT2 inhibitors, creatine, DAPA-CKD, and EMPA-KIDNEY, and one with semaglutide, the FLOW trial. All of these trials were stopped early. Published results were based on an accrual of 69%, 75%, 93%, and 87% of planned events in creatine, DAPA, EMPA, and FLOW. I did not know that. First point they made is that stopping trials makes it harder to sort out important signals, such as, for instance, the higher amputation risk noted in the CANVAS trial, which was not confirmed in credence, but not ruled out either due to the low number of events due to the early stopping. Second point they made, the DAPA-CKD trial was stopped after only 60% of planned events. So when the results came out, there was a 39% risk reduction in the primary outcome. It was driven by mostly kidney components. That's fine, but there was also a statistically significant 31% reduction in all-cause deaths. And this was driven primarily by a 45% reduction in non-cardiovascular deaths, 36 versus 66 events. And this was largely related to infection and malignancy. Cardiovascular deaths were not reduced. So their question was, is non-cardiovascular mortality reduction related to infection and malignancy plausible or a random high of early stopping? My answer, it is likely a random high due to early stopping. Kaul and Butler then list the 4 major reasons for stopping trials early. Number 1, unequivocal benefit. 2, unacceptable harm. 3, futility. And 4 are administrative reasons such as enrollment or funding concerns. Now, the tension in stopping trials early comes in getting the information we need for estimating true effect size versus protecting patients. The authors cite an important systematic review from Bassler et al. In JAMA, and I will link to it because it's an important paper. And in this review finds that most trials that stopped early, especially those who had fewer than 500 events, fail to provide reliable and valid estimates of treatment effect, and is often overestimating a treatment effect by nearly 30%. Finally, the authors write, other unintended consequences of stopping trials early include inconclusive data on outcomes that are important to patients, such as survival, quality of life, or adverse events. Second, compromised ability in the future to conduct more definitive studies. Third, inappropriate comparisons of benefit or harm of drugs within a class across completed versus truncated trials. Finally, unwarranted publicity and market share or potential undue skepticism regarding reimbursement or prescription decisions. In my comments, I highlight this important piece for its details regarding the CKD trials, which I did not know about, but more for the important considerations of trials that stop early. When we, the users of clinical evidence, interpret such studies that stop early, we need to consider that having fewer events increases uncertainty. And sure, this may be reflected in wider confidence intervals, but still, we should approach such trials with caution. Likely, this is the reason we see overall mortality benefit in DAPA-CKD, but no cardiovascular death reduction. There will always be a debate about early stopping of trials, but having thought about this for a while, I've come down on the side of avoiding it and trying to maximize the evidence that we get from a trial. And finally, just a very short note, I discussed the important SHAM-PVI trial on the September 6th podcast. SHAM-PVI was the first sham trial in AF ablation. I wrote about the trial, and there's a column up on the heart.org Medscape Cardiology site. And right after I finish recording this podcast, I will speak with the investigators in an interview, and look for that video interview coming soon. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And if you like this podcast, please consider taking the time, giving us a rating, writing us a review. I love the comments. They really make me think, and so thank you. Until next week, this is John Mandrola for the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.